Brian, you and Brian Folk have covered treatment of the glenohumeral joint, the AC joint, scapulothoracic problems. I assume you would agree that therapists also need to be scanning the thoracic spine as well.
Certainly.
If you've lost some end range motion, if you have some problems with end range cervical rotation, we wanted to try to transgress here to treatment of the upper thoracic spine. Many years ago, you discovered a technique that was beneficial to the upper thoracic spine, oscillatory techniques. So we're going to talk about something that you referred to as reverse NAGS, okay? And a reverse NAG is a natural apotheosial glide. So in the treatment of that, I was going to just hit the high points of the anatomy and the position, and then we would love it if you would take us through how you kind of discovered that technique.
And I'll need a victim for that, but please go through the anatomy first.
So when you are treating the upper thoracic spine, again, let's say, for example, that you've lost some mobility for end range arm motion, you've lost some end range mobility in your cervical spine. If you locate the transverse processes on the thoracic spine, you recall transverse processes are always going to be about an inch lateral to the spinous process. The transverse process for what you're treating is going to be above the spinous process. Let's say this is T2. We know the transverse processes are superior to that. Once again, the analogy of pull the trigger on the gun, contact the transverse process. Drop the opposite thumb down. Make sure that you're on the same transverse process here. I'm going to take an accessory assessment glide by taking up the soft tissue slack, glide the joint, and then we'll proceed with an oscillatory technique for reverse NAGS. Up and forward, again, making sure you're thinking about that facet plane. Brian, can you take us through how you had a chance discovery of reverse NAGS and how that changed how you treated some of your patients in the clinic?
You know, when I was learning manual therapy years ago, we used to make a V between our thumb and index finger, and I hope that will show up. And we used to use it to locate on a spine and use it as a fulcrum for movement. You were testing motion at different segments. And I had a lady in once who had a very painful neck, all directions. And I sort of used this procedure in a lower cervical spine, and I held on to it. And instead of just checking motion, I moved it forward and up along the treatment. I just did that. And as I did it, she said, "That feels wonderful." Oh, I said, "Of course." And I just kept doing it. And after repeating this procedure for a while, she said, "That feels much better." Now, I'd never done this before, and suddenly I've got a patient spectacularly better. Now, in terms
of saving some time in the clinic, all of a sudden you've gone from having to get somebody supine or prone and treat them here, and now you're doing a weight-bearing mobilization.
Weight-bearing. Now, can I just say something about chance? Louis Pasteur years ago said that chance only favours in the field of discovery, chance only favours the prepared mind. Now, if you ever have, by chance, anything very significant happen when you're treating a patient, please have a prepared mind. Don't say, "Wasn't that great?" and walk away. Go home and think about it. And I thought about it, because this is how it came about. I thought, now, it worked there. Would it work anywhere else? And then when you take a spine and you look at it and you know your anatomy, I wondered if I could apply this procedure somewhere else. And you certainly can, as you've just shown. And so this is how you would do it with a real patient.
So are you trying to stabilize the upper segments above where you're treating?
Yes, well, when you say stabilize, not necessarily. All I'm doing here is stabilizing the patient, if you like, so that if I do any work here, they're not going to fly around. So I'm against the patient, and I'm just holding their head. Now, it could be that you might have to, with some people, hold the opposite shoulder. But you'll see why when we apply the technique. There is the hand position, as you've shown us. And you've got to find exactly where those transverse processes are. And the only way to do so is initially to push ventrally. And when you push ventrally, you will probably locate, if you just go up and down like my finger is, you'll suddenly find, hello, I'm in a little valley. Now, if you come out of that valley, you've got to go over the transverse process. You go over and into the next valley, and over and into the next valley. But once you're in that valley and you're located under the transverse process, you've now got a bony contact.
Right.
So when you move it, I've got a bony contact there, right there. If I keep that pressure in, keep that contact, I can now start doing a reverse nag. So let me just try it here on it. I've got to find it first. I've got it there, and I've got it there. Now, I've got a bony contact. I lower my arm, and I'm just going to come straight up. Now, it's not a gross movement, because you can't move it that much, but it's a difficult movement. And I tend, when teaching, to make it a unilateral movement, because people usually have a restriction on one side only. The head won't go right round, so that would be the side to which you work.
Right.
So you can use then your index finger, like you did, or you can use your thumb, say on this side, and some people can't use this bilateral technique because their thumbs are hypermobile.
Sure.
And I would think 1 out of 3 people, their thumbs are useless.
Right.
And short of a transplant, it just won't work.
Right.
And they have to, in fact, use their index finger on one side, then on the other.
Right.
But once they've located, they come straight up. Now, the indications, as you said, are for end-range rotation, and if you have a stiff flick spine, you can't get elevation anyway.
Right.
If I slump my spine, I can't get my arm up. So this area is important when dealing with shoulders, and it's important even when dealing with necks. Because once you get to this point, rotation is now taking place here.
Absolutely. And that's actually been shown in a recent article in Spine magazine, that you move your arm, you move your thoracic spine as well.
Everything. So. Yes, yeah. Now there we go, I'm up here. Can you feel that on there? Oh, I'll use my thumb, just for something different. Oops, I slipped. Now I'm on it. And I'm moving.
If I come back to that question I gave you about stabilization, if you saw a lot of movement in the head, then you could certainly stabilize the head as well, right, as you're doing the reverse nag, and not worry about moving someone's neck too much.
Now, I'm glad you raised that issue, because this is rather difficult, and you need, a bit of effort. And people, because they're using effort here, tend to rest on the head. And the consequences are headaches and a cervical disturbance.
Right.
And in the land of litigation, you don't do things like that. So you can hold the head, but don't lean on it, even if it's your mate. Now, that is
and there's only a small amount of motion in each one of these. If you get a little bit of movement above and below, it's all right.
Now, I'm just going to ask you, Ed, if you can notice the difference when I'm doing it correctly or incorrectly, and you're not a therapist, so you can be completely honest. Now, there I am. It's on the bone.
Yeah,
that's just soft tissue.
You're moving all around there.
Yeah, just moving all around there.
For the purpose, Brian, of making sure we're not going to confuse the viewer, a reverse nag is not an MWM.
No.
Right.
No. In my book, there are 2 techniques dealt with that are not MWMs.
Right.
One is called a nag, and the other is called a reverse nag. These are mobilizations applied to the cervical and upper thoracic spine. And the only reason I include them is that they're done, as you've already pointed out, when the patient is weight-bearing and sitting. You get a person down on their tummy, and their head's like in this position, and you mobilize the neck. When they get up, it's not successful.
Right.
And some people can't lie like that unless they, they have nasal problems.
Right.
But these techniques are in sitting, and if you get a result in sitting, you keep it. If you get a result in lying, you don't always keep it.
A good technique as well for treating those modern technology. We're all in front of computers, and our poor posture, they got the forward neck. You meet some of those people at cocktail parties.
Can you just put your chin forward? All of it. These chins here. Yeah. The head is jutting forward. And I get problems here. This is horrible. And you've got to loosen that area up. But
one other little pearl that you dropped there, I want to make sure the viewer remembers, is that you talked about if it's unilateral pain, then you typically go to the side of where the pain is?
Yes.
Okay?
Yes, this is usually 99 out of 100. I can't ever remember doing a reverse nag on the left side to get right rotation. And on courses, I will look at a room full of people and say, has anyone lost end range rotation? I will bring them out and I'll say, before I even start,
Right.
I will change this.
Right.
And I do.
So that basically proves the point that end range cervical rotation also involves the thoracic spine. So if you don't treat the thoracic spine, you may not get end range shoulder motion, you may not get end range cervical range motion, you may not be able to get someone's posture